Dr. Mohammed Tahir. He's invasive and non-invasive and general cardiologist. He has American Board of Internal Medicine and American Board of Cardiovascular Disease. He's working in DePaul Health Center, St. Louis, Missouri, Christian Hospital Northwest, St. Louis, Missouri. Dr. Mohammed, he will talk about troponin. What does it stand for? Welcome, Dr. Mohammed.
So it's a great switch, you know, from life-threatening burns to life-threatening sepsis. Now we have troponins. A bread and butter thing for me, and I'm sure in the emergency department, when patients come in for a variety of reasons, whether they are burns or they are sepsis, if they do a troponin, it would be elevated. What does it mean? And that's what all the talk is about, and that's where we're going to go. So, in the old days, you know, which is not very far away, if you had an elevated troponin, you would say this is a myocardial infarction, and you will go ahead and, you know, call the cardiologist. A lot of investigations would be done. So, it doesn't work. The right one? Okay. So, what are troponins? Troponins are proteins, and they are found in not only the cardiac muscle, but the skeletal muscles as well. And there are 3 subunits. We talk about troponin I, troponin T, and troponin C. Troponin C is something which is very common, which is shared both by the skeletal muscles as well as the cardiac muscles. But the genes that encode the troponin I and the troponin T, they have isoforms which can be differentiated, and so we can differentiate between the cardiac form from the skeletal form. So whatever I'm going to talk about is troponin T and troponin I, their sensitivity, specificity, and precision. They are all different depending, you know, which commercially available assay is used. So if a hospital A has used a troponin, it cannot be compared to a troponin from a hospital B if the commercial assay was different. So that's one of the most important message which is there. One of the other things is that the high sensitivity troponins have come into being, and the Europeans have been using it much more than the Americans have. But even what the Americans we are using it have created a lot of problems, because there are now a lot of patients who have elevated troponins, and what do we do with them? So these are the emergency department visits in the United States. If you see these figures, they're astronomical. Out of that, about 10 million of them in the whole of the United States would present to the emergency room with chest pain. And out of these, about 4 million approximately would be sent home, because either it was a non-specific chest pain or the initial troponins were negative. The EKG did not show any evidence of ischemia. They still have about 50,000 MIs in the next few months. So it's still not a very safe process, but it's there. Out of the 6 million which would be suspected of having some degree of cardiac disease, they would be kept in the ER and would have subsequent troponins done, EKGs done. 3 million of them would be sent home. 1.2 million will have acute MI, and they would be sent to the cath lab. And about 1.5 million would have unstable angina. 374,000 people with acute MI would die in the United States every year. Some with treatment and some without it. And that's the CDC website. You know, this is a slide which I took from there. So just coming back to the troponin, the one which I just, so if you look at it, these are all these troponin C, troponin T, and troponin I, they're all there. Basically, what they do is that they, in the presence of calcium, they regulate it and actually induce the contraction between actin and myosin, and that is the reason why a muscle contracts. When you have an when you have a cellular injury, whether it's ischemic, whether it's traumatic, what happens is that these troponins are released from the cell membrane is damaged, and from the intracellular to the extracellular space, and this is where we measure troponins in the blood. It has to be a significant amount, which is present for it to be measured and make sense. So different assays have different numbers which decide whether it's significant or non-significant. We won't go into the details. These are all the different companies in America who make these troponin assays. So as I said to you, the one from the top, Abbott, cannot be compared with Roche. Their troponins would be the assays would be very different. The numbers would be a little different. So we ought to know, so each hospital, once they decide that this is a company they're going to use, they have to stick with it. So the rapid exclusion of, so there was a figure which was less than 3, and they found that a troponin of less than 3 was very satisfactory, and they could send these patients home. And these are all the different assays, sensitivity and specificity, which was very comfortable for these patients to be sent home. So the next question comes in, what leads to an MI? And I know as an emergency physicians, the most important thing, majority of you are bothered, is that the patient should be moved out from the ER either to the cath table or to the CCU or to the cardiac unit. But whatever it is, if it's a type 2 MI, sorry, did I go back, forward, or what did I, yeah. So the type 1 MI, this is the MI which we are talking about when you have an acute ST elevation MI, where there is a plaque rupture, there is occlusion of the vessel, and you get an MI. So one of the definitions which is there for this sort of MI, there has to be a rise and a fall in the troponin. And that differentiates between a type 1 MI than a type 2 MI, which I'm going to talk about, and most of my talk is about the type 2 MI. And so not only that you have a rise and fall, there is a history which is very suggestive that of ischemia. There are ST changes or a new onset of a left bundle branch block on an EKG. Or there is volume loss, a loss of muscle mass on on a SPECT imaging, or you demonstrate a wall motion abnormality on an echocardiogram. So these are the features which distinguishes a type 1 MI. Things become a little easier if you have a ST elevation MI and a very significant history of ischemia. What happens when you have a type 2 MI? There are different scenarios. One is this, that it's all about demand and supply. This can be a demand and supply thing where there is a fixed atherosclerosis. You exercise, your demand increases, and you will have troponin leak. You can have a vasospasm, which will basically behave exactly the same way as this one. There is no fixed stenosis, but the end result is going to be the same. There is going to be elevation of troponin. In this one, we don't see any abnormality. It's a very smooth vessel wall. No plaques are seen, but it's a question of supply and demand. If you're anemic, your supply is, if it enhances, you are going to get a troponin elevation, and it will still be classified as type 2 MI. The problem comes in, how do you differentiate a type 2 MI, which is due to this fixed atherosclerosis, to a one where there is a demand and supply problem? So I have just gone through it. It's exactly the same. Some of the things which will cause myocardial injury. And if there is a rise and fall, will result in myocardial infarction, which we have all the other features of ST segments. Then some of the things which would give rise to elevated troponins are cardiac procedures. You go and do a PCI, you're going to damage the vessel wall, troponins are going to leak. Non-cardiac major procedures, I'm going to touch a little bit on the non-cardiac major procedures, which are a major problem at present, which is being faced because there is events and there is elevation of troponins. And nobody knows what to do with them and what the answer is. The other one is all tachybrady arrhythmias, atrial fibrillation, atrial flutter, supraventricular tachycardia will, if they are fast enough, will release troponins. Heart failure, supply and demand causes increased troponins. And renal failure, there is reduced clearance in renal failure of whatever troponin is released. It remains into the circulation for a longer period of time. And when these patients come into the ER, for whatever reason it is, it's a normal thing, that they would do these blood tests, which will include a troponin, and there would be a call that this is an MI. So these are some of the... So the gist of the thing is that the high sensitivity protein, they looked at it, and MACE is, we're talking about all-cause mortality, myocardial infarction, and coronary revascularization is MACE. So the high sensitivity troponin, they looked at these things and they found that if it was less than those figures where they would be concerned about ischemia, it was safe to send these patients home. So the numbers which had anything to is 2 and 1 in the 2 groups. So relatively safe to send these patients home if your high sensitivity troponin was normal. Same thing again, we are talking about these troponin numbers, and less than 3, greater than 3, and if anything went above that number, it was myocardial infarction, otherwise they would go home. So just going back again on these things, that myocardial infarctions have changed a lot, and now there are quite a few of them. There's a type 1, which I just discussed with you, acute ST elevation MI. Then we have a myocardial infarction, the second one, the type 2. The type 3 is a sudden cardiac death where there is not enough time left to do anything, but they usually have ischemia, and they usually die because of an ST elevation, and nothing could have been done by that time. And type 4 is the one when you do a stent placement, PCIs, intervention, you damage the intima, you get an elevated troponin. And the type 4 is the one where you have stent thrombosis. And this usually happens, in the old days it was the stents where the problem was. Nowadays it's usually the patients who do not take their dual antiplatelet therapy. And the last one is the myocardial infarction, which is associated with coronary artery bypass surgery. There exactly it's the same thing. When you anastomose a vessel to a vessel, you leak proteins, troponins. So, type 2 myocardial infarction. Myocardial infarction secondary to ischemia due to either increased oxygen demand or supply. Whether it's due to a vasospasm, due to anemia, hypotension, arrhythmia, all comes into this category. So I went through all these things about the type 2 MI. I don't have to go through it. It would be the same thing, the definition of why you say that it's a type 1 MI. A lot of discussion and controversy about type 2, what to do with these people. Now, 5 to 20% of patients who undergo non-cardiac surgery have elevated troponins, some with symptoms and some are asymptomatic, had a routine troponin done, and it's elevated. So, and that is where the whole thing is. How do you differentiate which of these type 2 MIs would require further intervention or some where you would not do anything? A very difficult question, especially in America, where malpractice is very high, and you have to be very up on the ball to make sure that what you're doing is right. It is also very important that you do not miss a critical coronary artery lesion by saying it's a type 2 MI and it's a question of supply and demand. And I'll show you a picture of a coronary artery where this has happened. So either you can have a decreased myocardial oxygen supply or an increased myocardial oxygen demand. Increased myocardial oxygen demand in very healthy people, if these long distance runners, if their troponins are measured, they do have elevation of troponin. So it's not recommended that after they have run a marathon that you should do a troponin on them. There are also increased risk of atrial fibrillation, myocardial fibrosis, marathon runners for a long period of time. So they have significant heart disease if they continue to do what they're doing. So it's not safe, that you continue to run for a long period of time. Okay. So some of the other conditions, of the decreased myocardial oxygen supply, we talked about anemia, respiratory failure. I don't know how common COPD is here, but it's a very common disease in America related to smoking with severe hypoxemia. Bradycardia, a lower heart rate leading to hypotension will reduce your oxygen supply to your brain as well as to the coronary blood vessels. And if you're old, there is likely to be some degree of coronary artery disease, and that may actually affect the oxygen supply. Hypotension, shock, vasospasm we talked about, and endothelial dysfunction. Coronary artery embolism is not something very common. It's usually seen in the sequence of endocarditis. I have seen a couple of coronary artery embolism where the infected material dislodged from one of the valves and caused an acute myocardial infarction. So tachyarrhythmias, supraventricular or ventricular arrhythmias, they will all increase the oxygen demand. Severe hypertension increase the wall stress and will also elevate the LVDP and will cause increased myocardial oxygen demand. So other causes, I don't think apical ballooning, I mentioned about the marathon. Apical ballooning is that Takotsubo syndrome, and that is something where you do not have any significant coronary artery disease, but they have marked elevation of troponins, and they usually end up on the CAT table, and that's where the diagnosis is made on the LV gram. A big list of elevation of troponins where you would see, and one of the things which is very important is pulmonary embolism and pulmonary hypertension. And it's not something, there was a time when troponins was very specific for myocardial infarction. It's no longer the case. All these things, aortic dissection, congestive heart failure, rhabdomyolysis, they will all give rise to troponins. Drug toxicity, renal failure, stroke, subarachnoid hemorrhage, cerebellum is also rich in troponins. So if you have a cerebellar infarct, you will have an elevated troponin. Critically ill patients, sepsis, very common. If you have sepsis, if the lactic acid is high, your troponin will be elevated. Burns, we just said, and extreme exertion. So this is what I was just saying, that when you have a type 2 MI, whether it's a question of supply and demand, the question is there any significant coronary artery disease, and what do you do? So that's, if you see there is a significant lesion there, and you have to believe what I say, that this is a diagonal coming out from the LAD and has a proximal and an ostial stenosis. So it's a hard decision, it's a difficult decision, what do you do? So it all depends on your history taking, your examination, your clinical judgment, that what you're going to do. So just two examples, a 14-year-old with the Wolff-Parkinson's Wolff syndrome had an SVT of 240 beats per minute.
2 minutes, please. 2 minutes.
2 minutes. Elevated troponins, no ischemic changes on the EKG. What do? You know that the likelihood of coronary artery disease in a 14-year-old is unlikely, and this is due to the increased demand. So you're not going to do it. The myocyte damage is secondary to tachycardia. So coming back to the 70-year-old man who had an inferior wall myocardial infarction, had a stent, and now has a hemoglobin of 7.3 and a PO2 of 45. So he's hypoxemic, he's anemic, he has a history of MI in the past, and he also has ST depression. Would it be safe to say it's a type 2 MI and not to do anything? That would be a hard call to call. So it would be a difficult one. It could be a type 1 MI because his troponins are elevated, or it could be just a question of supply and demand. Here, certainly you would do echocardiograms and something to figure out whether there's any wall motion abnormality or not. So this is something, this debate is still going on, what to do with these people and how to go. So myocyte necrosis due to clinical ischemia in a coronary artery territory or an MRI scan, imaging would be helpful. So perioperative myocardial infarction, I briefly touched on it, and type 1 due to fissuring, plaque rupture, and type 2 is due to the imbalance. There are a lot of things here, but which I've just mentioned, and I don't think I'll be able to go through all this, but there is something which is very important in on the ACC Cardiology Journal. Just before I left, there is an extensive review about troponins. And the last bit which they say is that do troponins if you feel that they are indicated and should not be done routinely on everybody who comes in, because it would lead to greater problems than it would give answers. Thank you.